How's everybody doing this morning? Can you hear me?
Yeah.
Okay, all right. Like Ken said, we're going to talk a little bit on toxicology today. I got like 50-some slides, so I'm not going to try to linger too much, but we'll try to get done on time. But I like toxicology personally. It's one of my favorite things. If I have any regret, it's not doing a toxicology fellowship. I did my residency in New York City, and they have a toxicology fellowship there that's second to none. Anyway, let's go on. So what we'll talk about today is acetaminophen overdose, mushrooms, tricyclic antidepressants, calcium channel and beta blockers. We'll touch base on cyanide, carbon monoxide, and we'll talk about some toxic alcohols. So what's my approach? Typically, and I say this to everybody, basically, when you do emergency medicine, I was always taught, you know, especially by Dr. White, are people sick or are they not sick? Really, if you could recognize that right off the bat, and believe me, you're going to miss things too. Somebody's not going to be sick, but they're going to be very sick, and you're not going to see that. And that still happens to me nowadays. But I think if you could learn to develop this you know, insight when you see somebody and you take a history and you do a physical and everything, if you go, this person is sick, you know, if you do that, I mean, you know, half the battle's already done and you're on your way to being an outstanding clinician. So, and I always say, look at the vital signs. So even like, I'll go into a room a lot of times and the patient's not hooked up to the monitor. It doesn't hurt to throw a pulse oximeter on the patient. You get an oxygen saturation and you get a pulse, right? You can see, is the patient tachycardic? Is the heart rate 105? You know, is their O2 sat 88%? I couldn't even tell you, I couldn't even begin to count on, you know, how many times I've walked into a room in the ER and somebody's sitting there and they're coughing or whatever, and they're not on the monitor. You know, I check their vitals. I'm like, oh shit, their O2 sat's 85%, you know, and their heart rate's 110, you know, I mean, it's, so, and the same thing goes for, you know, fever. When I was a resident, I used to have an attending that used to make me do rectal temps on all kinds of people. And so I do it, the nurses hate it. I'm like, I gotta do a rectal temp, but I'll do it myself, okay? I don't depend on the nurses. Do you check a rectal temp? No, or a rectal exam. I do it myself. So, you know, I found a lot of people with fevers and everything. So the important thing that I wanted to tell you about, you know, here is if the approach to a poison patient, you know, check the vital signs. Are they tachycardic? Are they bradycardic? Are they hypotensive? Are they hypertensive? You know, so on and so forth. Are they febrile? Do they, you know, because there's also concomitant illnesses too that people have. And be able to see, is this person sick or not sick? So you want to check your ABCs always. We're really a specialty of airway, breathing, and circulation, right? So, you know, that's vital. History on poison patients is often incomplete. I had an overdose, acetaminophen overdose just a couple weeks ago. Guy really wasn't giving you much information. Much of the information we got was from paramedics and that. And so, you know, I took it as that. So, and the other thing you want, was this a suicide attempt? Was this an occupational exposure? Or is this something accidental? And then you also want to find out about any co-ingestions and what time the person ingested this, you know, the poison. So, like I said, you also want to check EKG on people, especially, you know, even if they're not tachycardic. You want to check widened QRS, you know, prolonged QT, things like this. And check labs. We're all good at checking off these orders and getting labs on people, even if they have a runny nose. I see people are getting a CBC and a, you know, a CMP. So anyway, don't forget a serum drug screen. Importantly, too, make sure you check a pregnancy, you know, especially in females of childbearing age. An ABG, if you suspect, you know, like if they're hypoxic, you could check the ABG. I'm not real big on checking ABGs unless, you know, it's a respiratory issue, but, you know. And then suicide precautions. Don't forget suicide precautions. If you think somebody tried to off themselves by taking a handful of Tylenol and, you know, whatever, certainly you want to institute some suicide precautions. You know, make sure, I actually found, years ago, I found a lady in one of the rooms downtown, and she was trying to hang herself. She had a sheet, she tied it to the overhead light that, you know, that we use, and she was trying to hang herself. There was no suicide precaution. I mean, she just got there and she was already trying to kill herself even before we get this going. So, you know, make sure you do that, because if you don't institute that, have a sitter or do something, then, you know, it could be a bad outcome. So, you know, we always hear about activated charcoal. You know, when I was a little kid, I used to hear my grandmother say, if you take that, they'll pump your stomach, you know. But, you know, activated charcoal, really what you're trying to do there is increase the surface area by using activated charcoal, and therefore you decrease absorption. But, you know, people that drink any hydrocarbons, or if they drink bleach or whatever, lithium, potassium, or iron, these things are, you know, charcoal's not going to work. Gastric lavage, the stomach pumping and all that, too many risks. If poison control says go ahead and do it, then you could do it, but I've never had poison control tell me to do a gastric lavage. Whole bowel irrigation, you know, go lightly. This is something you want to use in a patient that's awake, and this is typically what they would use. We're not really a big port of entry for, you know, heroin and cocaine here, and, you know, in Youngstown, at least not in Youngstown, you know, but, you know, you work in any of the other places, like say you're in Phoenix or you're in Miami or, you know, things like that where people would be, you know, smuggling in drugs, then certainly you want it to, you know, use go lightly. Sometimes people get pulled over by the police and, you know, eat their, you know, 10 bags of crack or whatever they have. You know, that might be, you know, something you could use this on, but I've never really have used it myself. Hemodialysis is another way to, you know, to help, but mostly this is drugs in circulation. These are drugs that are typically like lithium, aspirin, alcohols, things like that, that are rapidly absorbed into the stomach. They don't sit in the stomach for a long time. You could, you know, you could dialyze these folks. So we'll talk a little bit about acetaminophen. Actually, it's N-acetyl P-aminophenol. That's really what it is. Short, acetaminophen. It was first used in 1955. It takes about 45 minutes once you take, you know, a dose of Tylenol. It takes about 45 minutes to work, and it peaks in about 4 hours. We all know it's metabolized, you know, via the liver. It is the leading cause of acute liver failure in people. There it is. There's going to be a test on this. I want you guys to remember this and draw it out at the end of this day now. But basically what it is so you have your acetaminophen right here, and through multiple, you know, through a few, you know, sulfonation and whatnot, it basically turns into really a harmless metabolite. The problem is when you overdose on acetaminophen, you stress out the ability for the glutathione to conjugate and make this harmless metabolite. What ends up happening is it becomes this NAPQI, and this is really what the toxic portion of the acetaminophen is. So you only have so much glutathione to go around, right? And what people end up doing is taking an overdose of the acetaminophen, and you know, so the glutathione is working so hard, and there's only so much of it that this is actually gets produced, and then this is, like I said, is what's bad for the liver and causes hepatocellular damage. Like I said earlier, it basically binds to the NAPQI, results in non-toxic cysteine and mercaptate. But when it's produced faster than the glutathione can reduce, you get this, you know, what we call Tylenol overdose or NAPQI poisoning. So really, acute ingestion of 140 milligrams per kilo or greater than, or 7.5 grams in an 8-hour period will result in toxicity. And there's 4 stages that people go through. Usually less than the first 24 hours, people could be completely asymptomatic, or they can, you know, have some nausea, vomiting. Usually anything after that's when you start noticing symptoms. You know, right upper quadrant pain, the liver enzymes will start going up. You know, after you know, 3 days or so, people become, you know, if you overdosed 3 days ago and do nothing about it, you know, then you'll start noticing, you know, clinical signs such as jaundice, acute altered mental status, elevations in their coags, and it also will eventually cause renal failure too. And then if they make it past this stage without treatment and they've gotten past 5 days, then there's a good chance that they'll live and do well. Okay, but you know, I don't, you know, we usually, I don't know what this, you know, the literature is on how many people make it past that point, but you know, if somebody, I guess if somebody comes to the emergency department and says, 6 days ago I took, you know, 8 grams of Tylenol and, you know, all at once or something like that, you know, and you're like, well, you're going to make it. So, but, you know, if it's less than that, then certainly, you know, they're in trouble. You know, they could be in trouble. We don't know. So what do you want to do for these folks? Check their labs, serum, urine, drug screens. Like I said, check acetaminophen levels. What time did they take it? If they've taken it less than 4 hours, you could usually start activated charcoal. There's this Rummick-Matthew nomogram. It's actually an outstanding clinical tool for determining whether or not somebody needs N-acetylcysteine. What the N-acetylcysteine does, it helps replenish the glutathione. So this way there, now you have plenty of the glutathione to, you know, metabolize that NAPQI. This is a picture. Typically, you have your treatment line here. You see it starts at 4 hours. Like I said, acetaminophen usually peaks around 4 hours. So that's when it starts. I'll be honest with you. You know, if somebody comes into the emergency department and they're cogent and they said, you know, I took, you know, a whole bottle of Tylenol or whatever, I'm not going to say, well, what time did you take it? Oh, an hour ago. All right, let's wait 3 hours. I'll call poison control, and they're like, and they always tell us this. Oh, wait and see what it is at 4 hours. You know what? Screw that. I'm going to treat them because N-acetylcysteine is really not going to hurt anybody, and just treat them. Why not? You know, that's my philosophy. So. You know, but anyway, you know, you could use this. I'm not going to go into it in great detail, but, you know, you certainly could use this. You know, if somebody says, well, I took it 8 hours ago, let's see what your level is. You know, I mean, you could do that. But typically, and like I said in the next slide, you know, when would you want to treat with the N-acetylcysteine? You know, if the APAP level's over the line, if it's elevated greater than 20 mics, AST elevated. Let's say you're not going to get any results in 6 to 8 hours. Let's say you're working in a small emergency department somewhere, and they don't have a, you know, they said, well, that's a send out, and that's going to take, you know, it's got to go to, I don't know, 5 hours away or something, and we won't get the results. The courier's got to come and pick it up. I don't, you know, in between Grubhub rubs, I don't know. But, you know, so basically you would treat them. But empirically, you know, literature says empirically, if you suspect it and it's past 4 hours, then you can treat. But I basically, my clinical practice, I treat them. You're not going to hurt them, and, you know, and sometimes people are incorrect, you know. They'll tell you, I mean, I've had overdose patients come in and they'll say, I took lithium, I took digoxin, I took, you know, 200 Klonopin, and they're wide awake, you know, and you're like, come on, man, something ain't right here, you know. So even with like the acetaminophen, people could tell you they took a handful, a whole bottle. The history, like I said earlier, is always so incomplete that, you know, you don't know what to do. So I just typically treat them. IV versus PO, equal efficacy, okay? PO, there's like 50% of people could develop nausea and vomiting. IV, there's a very, there is a risk. It's very low though. 2 to 6% can develop anaphylaxis to it. But still, it's not enough to like delay treatment or anything. You know, I'll just do the IV dose just to avoid people, you know, yakking stuff up and, you know, causing more problems. But, you know, your IV dose is 150 mg per kilogram over an hour, and then, you know, you do this. And typically, this is what we'll start in the emergency department. We might get here if the patient's still in there, but hopefully by 16 hours, they're up in the ICU. And then there's your PO dose, just like 10 milligrams per kilo less. You know, and then it's just, you know, 4 hours later you give, you know, and it's 17 doses. If you find yourself given this whole 17 doses in your emergency department, something's wrong with your, you know, your bed movement. So, what about pregnant girls? Why do I always say that, pregnant girls? Are there anything else other than pregnant girls, right? There's no like pregnant guys, right? So, pregnant females, treat as usual. IV NAC is pretty safe. Children, you could do NAC, it's not going to hurt them. But typically, for some reason, and I looked in several books, you know, there's not like a lot of information out there with the kids, but hepatotoxicity is rare in children. But nonetheless, it does exist. You could treat with you know, NAC. But a lot of times what happens is the kids, you know, 8, 9 years old aren't trying to kill themselves by taking a boatload of Tylenol. What they're doing is usually parents that maybe, oh, I gave them Tylenol every 2 hours or something like that. Their fever wouldn't come down, you know. So that's typically what happens there. So any questions or anything about acetaminophen? Everybody okay? All right. You know, you have your King's College criteria, which basically says this is when you need to get a liver transplant. Like I said, renal failure. If they're in that stage 3, 4 area, if their coags are significantly elevated, or their arterial pH is, after you've given them, sufficient amount of IV fluids. But, typically, like I said, I've never had to refer anybody out for liver transplant or anything. This is typically done in the ICU. So, but that's that. We'll talk real quick, speaking of the liver, we'll talk about mushrooms. Really, this is the mushroom we worry about. I know you're all going to remember this mushroom, so when you're in the woods, 10 years from now, you go, oh yeah, I remember that mushroom, yeah. No, we're not, but this is a bad, what happens is, a lot of times, this happens, a lot of these ingestions happen in, like in the West Coast, California, Oregon, places where there's a lot of immigrants come in, and in wherever country they come from, a lot of times real edible mushrooms resemble what we have here. Even our own people here that have lived here all their lives, that are mushroom hunters, will sometimes go and accidentally ingest these mushrooms and everything. They really are. It's bad. It really is, and I'll tell you why. Because what happens is it's due to this heat-stable cyclopeptide. So you could cook the hell, you could fry, you could bake, you could broil, whatever you want to do, right? And this toxin is still going to be there. So no matter what you do, this alpha-amanitin it doesn't go away. It remains toxic no matter what. But the tough thing about it is so people could come in to your emergency department and be like, hey, listen, I have, nausea, vomiting, diarrhea. You're like, okay, sounds like gastroenteritis. Here's some Zofran, or here's some, Lomotil, whatever you want to do. Follow up with your family doctor in, 24 to, 2 to 3 days, but they're dead by that time, right? Or they'll come back, more sick, multi-system organ failure, hepatic failure, usually within, 2 to 3 days. 1/3 of adults will die. The mortality rate is greater in children. So there's no antidote. Really what you could do is IV fluids, activated charcoal. You could actually use ceftazidime, and it actually competes with the toxin at the at the hepatocellular level. You could also use, I can't even talk. You could also use silymarin, PO. It replenishes glutathione. NAC also will help the glutathione. But in most cases, when people get to the point where they're really sick, really the only cure is really an emergency transplant. So, you could try some of these things. It might buy you a little bit of time. It might buy them some protection. But typically, if they don't get a liver transplant, then it usually means death. That's mushrooms. We'll talk about tricyclic antidepressants, okay? And the reason I kind of think this is important now, because of the war on opioids, we're finding so many more different modalities for pain control. And now, so tricyclic antidepressants never really went away, but they weren't used as much, and now they're coming back. So for like 20, 30 years, they were the most widely used antidepressant. And now, because we have SSRIs and NSRIs and everything, it's kind of, it's not used as much. But anyway, people still are prescribed them. There's, people still take them a lot. They use them for migraines. They're used for attention deficit disorder in kids. Basically, what they do is just inhibit serotonin and norepinephrine uptake. They're rapidly absorbed. But however, in overdose situations, they cause both cardiac and CNS toxicity. If you think about your heart, your SA and AV node are calcium dependent. However, your bundle His and your myocardium are sodium dependent. The tricyclic antidepressants block your sodium channels. They delay depolarization. What happens? You get a widened QRS on your EKG. Okay, so somebody that comes in and you suspect they've taken a tricyclic antidepressant overdose, you immediately get an EKG and you look, and let's say their QRS is like 0.15, right? Then you're like, oh boy, look at this. What do I do? And I'll tell you in a second, but this is basically the hallmark of tricyclic antidepressant toxicity. You also get, because it has some anti-muscarinic and alpha blockade effects, you will develop tachycardia and hypotension as well. It also has antihistamine effects. You develop altered mental status. And it also, some of the tricyclics also antagonize the GABA receptors, which will lead to seizures, which could lead to acidosis. And then acidosis will increase or exacerbate your cardiac toxicity. Treatment, activated charcoal. The big thing here really is sodium bicarb. You can break open the crash cart and grab you can get 50 cc's of sodium bicarb from the crash cart, give them boluses every 3 minutes or so. Just monitor the EKGs. You want to target the pH to 7.5 to 7.55. You can give them Ativan if they're seizing, norepinephrine for actually counters the alpha blockade that people will get as well. And but typically the mainstay of treatment is your sodium bicarb, which you could just give. And you monitor the EKGs. You could do it to QRS narrowing. Beta blockers, we'll talk a little bit about that. Right now there's 19 of them. They're used for multiple things: anxiety, hypertension, migraine, stage fright. People that come up and speak before a large audience, they can certainly take a beta blocker to help calm them down. And basically what it is they block the, your beta-1 receptors on your heart are stimulated by your norepinephrine and whatnot. What the beta blockers do will sit on those receptors, block them, and not allow, and really the reason they work for high blood pressure is they slow your heart rate down, right? And in doing so, lowers your blood pressure. But what tends to happen, the beta receptors get stimulated, they release cyclic adenosyl monophosphate, which in turn releases, calcium into the sarcoplasmic reticulum and whatnot, and then allows contraction. So, like I said earlier, the SAAV nodes are calcium dependent. Your His and your ventricle, your musculature is sodium dependent. So, but in this way, this will stimulate a contraction through the SAAV node. And what we're doing is we're blocking it, and you're decreasing those contractions and decreasing the heart rate. However, what tends to happen with people, just real quick, there's lipid soluble, water soluble. There's really two types. So you want to think, I didn't list which ones were which. Other than just these propranolol and metoprolol. Most people are prescribed metoprolol and that, and you get some people that are on atenolol, not as much. I see so many people on metoprolol though. I don't really see too many people on propranolol. But typically an overdose on metoprolol is hepatically metabolized. There's a way to get rid of that. Atenolol, renal, you can dialyze those folks. Propranolol has sodium channel blocker, tendencies. You can develop QRS widening with that. Sotalol, usually sotalol is prescribed by your EPSs, and those can cause QT prolongation. Carvedilol or Coreg has some calcium channel blocker tendencies, and for that you can get vasodilatation. But mostly people will get bradycardia, hypotension, they can develop bronchoconstriction, and like I said earlier, propranolol can cause central nervous system effects. Calcium channel blockers, there's 10 really that are currently FDA approved. Raynaud's, subarachnoid hemorrhage, dysrhythmia, people that are in chronic AFib, right? They get cardizem, things like that if they don't get metoprolol. Anyway, so real quick, the L-type calcium channels open during AV depolarization, and in there the calcium initiates myocyte contraction, almost, But the problem with the calcium channel blocker is they're the calcium channels are like the terminal event in the whole cardiac conduction. So, once you get to that, you terminate that they're a lot more dangerous. What I'm trying to say is the calcium channel overdoses are a lot worse than the beta blocker overdoses. Pancreatic beta cells release insulin. This is important because what tends to happen is insulin doesn't get released. Also arterial smooth muscle, which is calcium channel dependent as well, right? And that's why we give people, calcium channel blockers. Their way of working, one way of working is to not allow calcium influx into the arterial smooth muscle, and therefore open up the arterioles and that a little bit more, then decrease in blood pressure that way. However, you get basically the arterial smooth muscle is responsible for vasoconstriction. So, the calcium channel blockers will vasodilate. You have your dihydropyridines like amlodipine or Norvasc, as we all know it. And like I said, that causes a vasodilatation. Then your non-dihydropyridines, such as cardizem and verapamil, are more cardiac targeted. So depending on, which one they've taken, you might get different effects. Like I said, your overdose on calcium channels are worse than your beta blockers because the calcium channels are your final pathway. People will get hyperglycemic, they'll get bradycardic. The most clinical significance you'll find is hypotension. Verapamil is the most lethal. I think we talked about why. I don't want to take up too much time, but yeah, because verapamil, for some reason, I can't remember now, I'm sorry, I apologize, but verapamil is if somebody says they overdosed on verapamil, you want to set up an extra set of antennas because that's a little bit worse. But let's get on with the treatment is basically, like I said earlier, ABCs, monitor, EKG, IV fluid, check a glucose, and call poison control, right? Activated charcoal if they've done it 1 hour post-ingestion. But the big thing is you want to increase the calcium gradient, right? You want to get their calcium in their body, so you can use calcium gluconate. Okay, you could use atropine pressors, but the big thing is calcium gluconate. You could use glucagon because you want to increase that CAMP production to increase calcium, and also you're going to use high dose insulin, right? Because what's happening with this is the pancreas can't secrete insulin, so you get hyperglycemic. So then what ends up happening there is no insulin. It's like having a rapid bad type 2 diabetes, right? So insulin, which carries glucose to the cells in the body, right, is knocking on the door, but it can't get in because it doesn't, typically when you don't have the insulin, the glucose is just floating around and it's not doing anything. So you want to give people high dose insulin. It's usually 1 unit per kilo bolus and then 1 unit per kilo per hour. And this is very favorable for the heart because the heart is stressed out. It's starting to favor the carbohydrates. And then so what the insulin does is you give them the insulin and it shuttles this glucose into the myocardium and into the rest of the cells and everything that need the glucose. So like I said, typically, like if you have type 2 diabetes, right, you're insulin resistant. So, the glucose, which is being carried by the insulin, is trying to get into the cells, but the cells are like, listen, their fire marshal says there's standing room only, we have no more room for you, get out. So, the insulin just puts the glucose into the fat, right? In this case here, what's happening is you have glucose floating around the body, but you don't have no insulin really to get it into the cells. So, and then people end up hyperglycemic and their body can't use is demanding glucose and it can't get it. So what's the treatment? Propanol, like I said earlier, has a little bit of a sodium channel blockade to it as well. So you want to use sodium bicarb, increase the sodium gradient. Hemodialysis, atenolol because it's renally excreted or renally metabolized. You could use this intralipid soybean oil. Really, that's really for only impending arrests. Just because someone said they took, 5 or 6 cardizem doesn't mean you call pharmacy and go, listen, I need to get the, start, intralipids on this patient. And there's also methylene blue, which takes up nitric oxide and helps reverse vasodilatation as well. Don't really use it. I've never used it. I don't know. I guess, the studies are still, but typically if you think someone's going to arrest or whatever, you could use this intralipid on them. Everybody got that? Calcium channel blocker, beta blocker, is that okay? Let's talk about cyanide real quick. Cyanide's a colorless, bitter almond odor gas. It's associated with smoke inhalation, suicide, crime. I'll tell you the story real quick. A few years ago, I go to Akron General and I give a lecture on toxicology and I talk about cyanide. And one of the attendings comes up to me after the lecture and says, it's interesting that you gave a lecture on cyanide. You want to know why? I said, no, why? He goes, a few years ago, there was an accident on 76 One of our attending's wives got in her car, was driving on 76 and hit a barrier and was dead on the scene, but they brought her in as a trauma. And we tried calling her husband to tell him that, you know, your wife unfortunately has died. She was in a car crash and everything, and nobody can get a hold of the guy. Well, he's supposed to show up for his shift at 7 o'clock that night. He never showed up. And so they went to his house, police department, everything. Couldn't find the guy. Well, here, he gave his wife cyanide somehow, and she was drinking her coffee when she was going down 76, and it pretty much killed her right away. And the reason he did that was because he took off to back to Greece or somewhere, Macedonia or whatever, with the one nurse that he was fooling around with up in the ICU. So, yeah, so he's in prison now and everything, but, you know, I say, you listen, you know, just divorce the poor gal, you know? I mean, why murder her? I don't know. Anyway, his family was very wealthy, and they kept him overseas for a long time, and finally he got extradited, and, you know, then it took, I don't know, 10 years for the state medical board to revoke his license. I don't know. But anyway, you know, most of these people that die in fires and everything don't die because they're burned to death. They die because of smoke inhalation, and it's usually due to cyanide and carbon monoxide poisoning and everything. Just some incidences. Happy Land Social Club fire, 1990, up in the Bronx, actually. There was a guy that was mad that he seen that his girlfriend was dancing with another guy at some nightclub, so he set the place on fire and killed 87 people, including his girlfriend. We all know World War II history. Zyklon B was the cyanide. And a fascinating thing is People's Temple. 913 people killed themselves, not with Kool-Aid, but with a different kind of mix. It was like, you know, Flavor Aid, I think was what it was. Jim Jones was a fascinating character. He came out of Indiana, moved to San Francisco, and that had a huge cult following in San Francisco. Actually, there was a lot of people that were in the, you know, the mayor and just a lot of people in city council and everything really liked Jim Jones. He did a lot of good for a lot of people. You know, they started, kind of following him, not following him, but, you know, he was in high circles, if you will, high social circles. Well, he ended up moving all his people to Guyana down in South America. And there was people writing letters, because back at that time, we didn't have cell phones, right? You didn't have the internet. You didn't have stuff like this. People wrote letters back in back home and saying that this guy's a maniac, you know, he's having, you know, sex with the young girls, he's fathering a lot of children, he's always high on drugs, he's mistreating a lot of us, whatever. So there was a guy, Leo Ryan, he was a congressman from California who took an entourage down to Guyana to go investigate, you know, his constituents and complaints. And so as he was leaving, Jim Jones unleashed his guards on Leo Ryan and the rest of his congressional staff, and they all got shot to death. And then Jim Jones, who was a madman, because he was usually high on a lot of drugs and everything. He was continuously doing drugs. He wore sunglasses all the time and everything. Basically, got on the loudspeaker and told all his people to get in line, and, you know, the end is near, they're coming for us, and you know, they're coming to ruin our beautiful thing, and so on and so forth. So 913 people followed the guy, you know. You know, I don't know. I can't get most people to listen to me, you know, one person. This guy had 913. I don't know. You know. But yeah, it's a fascinating, there's books been written on it, there's movies about it, you know. It's just, what fascinates me is just that, you know. It's that this guy had such charisma and character and everything, that he actually had such a huge following. He actually, you know, coaxed 913 people to their death, you know. It's just fascinating. In 1982, the reason why we have wrappers and everything, and why it takes forever and a day to get your bottle of Tylenol or Motrin or half your stuff open, is because in 1982 in Chicago, somebody tainted Tylenol with cyanide. They've never found out who did it to this day. The FBI still has an open investigation. They still haven't found out. There was one person of interest. It was this old man by now. He lived in New York City, and he ended up dying, so they never got to really elucidate whether it was him or not. Yeah, so cyanide, bad stuff, kills you pretty quick, interferes with your electron chain, prevents your hydrogen NO2 from binding, and what ends up happening is you just get acidemic from the excess hydrogen and die. seconds to minutes symptoms, headache, confusion, seizure, coma, death. Done. So. Treatment, if you do get somebody and you're able to treat them, you know, smoke inhalation, things like that. If you suspect maybe a little bit, you could use this cyano kit. We used to use amyl nitrate, sodium thiosulfate, but however, the amyl nitrate and the sodium nitrate metabolize to methemoglobin, which is not good because if you suspect a concomitant carbon monoxide poisoning, now you're really going to, you got their hemoglobins bound up with carbon monoxide, or, you know, and, you know, the methemoglobin as well, so not a good thing. So basically we use a hydroxycobalamin in the Cyo kit. It's cobalt, it forms B12, and you could use the sodium thiosulfate, which gives it a sulfur moiety, and you get the thiocyanate. So relatively safe. You know, you could use this people that come from a fire or whatever. If you suspect maybe some degree of cyanide poisoning, you could use it. Carbon monoxide. I know winter's almost over, thank God, but you know, leading cause of poisoning in the U.S. is really carbon monoxide to this day. Faulty furnaces, space heaters. It's a colorless, odorless gas, so people don't even know they're being poisoned. But it binds to hemoglobin stronger than the oxygen does. But you have a normal pulse ox and everything, but because the hemoglobin is holding on to the oxygen, or the carbon monoxide is holding onto the hemoglobin more than the oxygen is. It's not dropping it off at the tissues. And so people end up getting hypoxic in that. Headache, dizziness, nausea. I gave this lecture last fall, and the thing I wanted to stress was this headache, dizziness, and nausea is sometimes in the winter confused with people just having a viral syndrome. So, but I want you to know that in the wintertime, anybody that comes in with anything like this, maybe like the husband and wife, or the wife, or you know, the mother and 2 kids, things like that, always suspect some degree of carbon monoxide poisoning. Could be possible. What's the treatment? 100% oxygen, put them on a non-rebreather. You could check labs, a VBG, you don't need to do the ABG. The VBG is just as well. You could do a lactate check, an EKG. Just remember that the levels are not predictive of symptoms as well. And people that smoke will always have a little bit higher levels. What about hyperbaric oxygen? We do about 1,500 hyperbaric treatments a year, but the evidence is not there, but it's just like TPA. It's a standard of care, right? So you send them off to the hyperbarics. The issue is with those hyperbarics, by the time you get somebody to the hyperbaric chamber, you've already treated them with 100% oxygen, right? So by this time, their CO levels are pretty much decreased. So you're, you know, but you send them off anyway. I had a patient come a couple years ago all the way from Canton to get hyperbaric treatment because their hyperbaric chamber wasn't working, so they sent them downtown. And I mean, the mom and the baby were both very lucid and talking, and all right, here you go, we'll send you over there, you can get it done. But anyway, so that's that. Toxic alcohols. Let's say you're working in the ER, you have a 28-year-old agitated and intoxicated male from home. His cousin found him on the couch unconscious. Now he comes to the ER by saying, ooh, and F you, which, you know, I mean, it's common, not surprising, right? Smells like fruit. What'd this guy do? Eat like a bunch of bananas or something? I don't know. But his cousin says he's alcoholic and he drinks daily and he's trying to quit. You look at his vital signs, besides being a little bit tachycardic, the rest of his vitals look okay, right? What's your approach? Once again, so if you suspect a toxic alcohol poisoning, I've said it before, ABCs, vitals, history, any co-ingestions, anything like that. Do you notice any odors? Diagnostics, you know, certainly your labs, we all know how to do labs and everything. Make sure you look at your bicarb and your anion gap too if you suspect that, and I'll tell you why. And when would you suspect toxic alcohol poisoning? People are trying to quit drinking, you know, will end up, you know, panicking. They don't want to go into withdrawal. They might drink antifreeze or methanol or some. How about people that can't afford, you know, can't afford liquor or beer, right? Somebody with limited access. I had a guy one time about 4 years ago, you know, those little hand sanitizers that we have in the emergency department that are outside every room. They had one in the drug and alcohol place where the guy was staying at, right? So what the guy do? Right? It's really weird, I know. So, but, you know, he had limited access to alcohol, so he decided to drink that. If you look at that stuff, it's damn near straight gin, so I don't, you know, but anyway. Suicide attempt, then you have idiots, okay? Watch this kind of thing. So really, what is an alcohol? It's really a hydrocarbon combined with a hydroxyl group. Ethanol, we all know ethanol, beer, wine. Joey knows Four Locos, right? I'm just joking, she don't know Four Locos. Four Locos, I think, is like some kind of energy drink or something mixed with something. I know they sell it in the drive-thrus. You have antifreeze, ethylene glycol, windshield washer fluid, methanol, and your isopropyl rubbing alcohol, which is the same stuff that we get out of the hand sanitizers, and also you buy at the drugstore real cheap. Toxic alcohols, obviously, anything you could take is toxic, right? But typically when we refer to toxic alcohols, we're talking about mostly your antifreeze, your windshield washer fluid, and your rubbing alcohol. Your ethanol, which most of us drank on St. Patrick's Day or the day before, you know, your beer, wine, Four Locos, are they toxic? Well, yeah, but typically they don't result in, you know, bad, you know, like what I'm going to talk about here. So this is why we worry about them more. So your toxic alcohols have toxic metabolites. Your glycolic acid and your formic acid will form a metabolic acidosis, and your acetone will form ketosis. So, but typically your ethanol that we you know, enjoy is metabolized to acetic acid. So that's really not toxic, okay? I know you feel like crap the next day or whatever, or for 2 days. The older you get, it could be 3 days, but you know, it's really not toxic like drinking this other stuff. Metabolic acidosis, really I'm not going to get, it's just basically an excess of protons, so you get acidotic, right? BMP, your bicarb is less than 24 and or you have an elevated anion gap. VBG, usually your pH is a little bit lower. I'm not going to get into the anion gap. Toxic alcohols, alcoholic ketoacidosis, methanol, metformin. This is what will cause your metabolic acidosis, right? Alcoholic ketoacidosis, methanol, metformin, uremia, DKA, paraldehyde. You guys know what paraldehyde is? Anybody? Paraldehyde is actually was an excellent sedative hypnotic that they used a lot in the 50s and 60s. They haven't used it since then. It's a great anti-epileptic for kids. It's very safe, just don't use it much anymore. You always had to mix it with like a juice or something like that with a metal spoon. People would drink it. That'd be out pretty quick. However, leaves a bad taste in your mouth, hepatically metabolized. Just fallen out of favor now that we have, you know, like Haldol and Geodon and stuff like that. So, and then we also have another, you know, you got Keppra, all these other anti-epileptics, but paraldehyde used to be it. Iron, NIH, you know, lactate, ethylene glycol, aspirin, and starvation ketosis. Your osmolar gap is an early surrogate marker for toxic alcohols, right? So basically what you're giving is elevation of your low molecular weight. Molecules are elevated, however, they're reciprocal with your anion gap over time. So as the low molecular weight molecule goes down, your anion gap goes up. It's really neither sensitive nor specific. I've gotten chewed out by ICU doctors for not getting it. I think it's stupid. I don't use it, whatever. But just to say what it was. It's not going to guide you either way, I don't think. Ethylene glycol, it's an engine coolant with a sweet taste. Not that I've tasted it, but your alcohol dehydrogenase converts the glycolic acid, converts it to glycolic acid and oxalic acid. Glycolic acid, it causes the metabolic acidosis. Your oxalic acid causes calcium oxalate, which deposits as kidney stones and is nephrotoxic. Methanol, windshield washer fluid, the alcohol dehydrogenase converts it to formaldehyde, then formic acid, which then is retinotoxic, irreversible, okay? Not good. Treatment, ADH inhibition, after you resuscitate them. You could use ethanol. However, there have been deaths from people being treated with ethanol. Places are like, you know what, fomepizole costs too much money. Just put them on, you know, an ethanol drip. It needs constant monitoring, and there have been, you know, people that have died from that. So really, the treatment is fomepizole. Who cares? Spend the hospital's money. You're trying to treat the patient. It has a high affinity for the alcohol dehydrogenase. Your treatment is 15. Your dose is 15 milligrams per kilogram bolus IV. You could dialyze someone as well, and you could also give them bicarb, folate, and thiamine. I typically, and I'd say this people say, well, should I start them on a banana bag? No, because chances are, once they get out of the hospital, they're not going home to start you know, a healthy diet, and quit drinking and start working out, okay? It's just probably not gonna happen, not right away. So why give them all these vitamins? What's the big deal? Is there any, you know what I mean? You can throw a vitamin at them as well. So I don't know, I never used that banana bag personally. Isopropyl, people can drink rubbing alcohol, hand sanitizer. It's a lot more common than the other ones. Basically, you get ketosis from this. What do you do with the ketosis? Really nothing. Just give them IV fluid, supportive care. You could do the banana bag. The problem with these isopropyl, GI bleed's a little bit more common, so you might want to use a PPI. But you keep them there until they're sober. You know, a lot of times people that are drunk, you know, if they get a ride home, somebody comes and picks them up and they're completely sober, that individual, you could let them go. But typically maybe for something like this, I probably would want to keep an eye on them for a little while until they're sober. They might need social services and stuff like that. It's got to be a reason why you're drinking rubbing alcohol, right? So anyway, we'll finish up here. Just the principles that I want you guys to know. You know, try to get your history, ABCs, vital signs, all that. When taken, how much, any co-ingestions, anything like that. Get everybody IVO2 monitor if you suspect an overdose. Check your labs. Don't forget to get a pregnancy. And pretty much get a hold of poison control as soon as you can for further guidance. And that's that. Any questions? Everybody okay? Okay, thank you.